Friends, welcome to my workplace at Ranaghat, West Bengal, India. Let us observe this surgery totally unedited and in real speed. This is an intumescent cataract. The main incision is being made with a steel keratome at mid-limbus at around 11 o'clock. And now a side port is made on the left side of the main wound about 3 clock hours away. And now we have to stain the anterior capsule with trypan blue dye for better visibility and for doing capsulorhexis. An air bubble is injected. Beneath this air bubble, trypan blue dye is applied over the anterior capsule. The dye should touch all parts of the anterior capsule. This is a little bit of adrenaline, and now excess dye is washed out. We can see this very good staining, and this is in a real speed. So in less than 30 seconds, we have got very good staining. And now capsulorhexis. First, a minirhexis. Utrata forceps is being used for this minirhexis, and in this case, see the minirhexis. It has taken the shape of an apple. And now our job is to go through this opening and remove cortex as much as possible. The decompression of the capsular bag causes intralenticular pressure to drop drastically, and the chance of rhexis run out becomes zero, almost zero. The anterior chamber is again filled up with 2% SPMC. A venous scissor is taken and a small cut is made at the margin of the minirhexis. Utrata forceps is taken again, and an optimum sized rhexis of about 5.5 millimeter is done at this time. And now we have to manage the nucleus. Let's go again. The phaco handpiece is taken. The exposed part of the tip is about 1 millimeter, and we are going to do direct chop. Since the nucleus sclerosis is on the harder side, about grade 4, I am going to do submarine chop. The tip travels through the substance of the nucleus and you do a nice cut. So in this way, the nucleus is divided into pieces. You have to hold the nucleus with vacuum and remove it by using ultrasonic energy. Settings. At this time, actually from the very beginning, in high vacuum, high flow rate, 480 millimeter of mercury vacuum and 48 ml per minute flow rate, and the ultrasonic energy was set at 80% in this case. And now we have to clean the cortex. Little bit of visco. This is because I am going to use the Simcoe through the main wound. If we want to use the Simcoe through the main wound, we should use some amount of viscoelastic substance so that anterior chamber maintenance remains good for some time. And now this is, I have to go through the side port and remove the cortex from 10 o'clock, 11 o'clock and 9 o'clock. thorough cortical cleanup is done, and then an intraocular lens is placed in the capsular bag. Hydroimplantation means we keep the antechamber formed by irrigation and an intraocular lens is placed in the capsular bag. The main wound is enlarged by 1 or 2 cuts so that we can use a B cartridge. In this case, the intraocular lens is of higher diopter, that's why we are using a B cartridge. The lens has gone in the capsular bag. The irrigating probe is used to place the lens in the right orientation. Viscoelastic moxifloxacin is injected into the anterior chamber. The side port is closed by corneal stromal hydration, and a final lavage is done at this time. Any visco that may stick to the corneal endothelium is removed. The antechamber is nicely formed. Integrity of all the wounds are checked by a cotton-tipped Johnson wort. Few drops of moxie is applied over the ocular surface and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. You will be more comfortable in managing intumescent cataracts.